Good morning, everyone. Welcome to the Swetland seminar. My name is Linnea Webb. I help coordinate the Swetland seminar series here at the Swetland Center. If you could please share your name and the organization that you represent in the chat box so we can see where everyone's coming from. If you're not familiar with the Swetland Center, in the late 1950s, David Swetland and Marion Swetland felt that not enough was understood about the unintended health consequences of chemical, agricultural, and industrial products in our environment. And at that time, there was little medical science that documented the relationship of diet and lifestyle to human health. So they focused the Marion Swetland Professorship of Environmental Health Sciences on preventative medicine and the threats of man-made environmental hazards, so that all graduating doctors would have an interest in and understanding of the impact of the environment on human health. Today, the Swetland Center continues Marion Swetland's legacy by building partnerships to find and scale solutions to redress the environment's disparate impact on low resource populations in Cleveland and beyond. As research continues to demonstrate the vital connection between the environment and health, the center is positioned to respond. And our mission is to study the complex interplay between environmental determinants and population health outcomes. The center places special emphasis on community-engaged approaches that address the role of structural racism in creating and sustaining environmental health inequities. We seek to translate these findings into policies, practices, and relationships that promote community and population health equity. And as you'll see in this triangle here, this represents our core areas of focus, so training and education, community engagement, and research. And if you're interested in learning more about the Swetland Center, you can check out our website at case.edu/Swetland. And you can also email us at swetlandcenter@case.edu. We do have quite a few upcoming events. And I did not get a chance to put this on here, but tomorrow, the Nutrition Equity Fund, they recently launched the Policy Action for Food Justice Grant, which will invest in coalition building to bring together local policy engagement for nutrition equity in Cuyahoga County, Ohio. And they're hosting an office hours tomorrow from 1 to 2 p.m. to answer your questions about the application. So I did put the link in the chat earlier, but I'll add it again just in case it got lost in there. And then August 11th, as you'll see here, this flyer, August 11th from 12 to 1:30 p.m. Our Nourishing Power Networking, we're adding this new Lunch and Learn virtual series. So it's an opportunity based on feedback from activities over the past year. We decided to add this to provide some technical assistance, advice and guidance on different topics needed to spark and expand community-driven food justice initiatives throughout Cuyahoga County. So the first event in this series will be Friday, August 11th from 12 to 1:30. And we're going to have two different guest speakers, Lauren Smith-Petta from Jumpstart and Tanisha Velez, founder of Cleveland Fresh and Herding for Life. And each of them is going to share about how to create a business plan specifically that sets you up for success when creating a food business or something in the food system. And then our next Swetland seminar, we will not have one in August. So the next one will be September 26th from 9 to 10 a.m. And Dr. Francisca Garcia Cobian Richter will, who's also a faculty affiliate of Swetland Center and research associate professor at the Jack Joseph M. Morton Mandel School of Applied Social Sciences at Case Western. She will present about FAIR2, a framework for identifying and addressing discrimination bias in social data science. And I also added the link to register for that in the chat, and I'll add that again just so you can all find it. Okay, so now I will turn it over to Dr. Friedman, director of the Swetland Center.
Darcy, I don't believe we can hear you. Apologies. I know you're unmuted on your screen, but maybe. Also, when we get Darcy situated, just want to make sure we're recording. Thank you.
All right, so I apologize. Do you hear me now? Okay. So I am so excited to see many faces on this screen, and many of you have been deeply connected to, involved with, and leading the seminar content that we're going to be discussing today around assessing community health needs to guide neighborhood level action for health equity. Our center in 2021 went through a strategic planning process where we thought about how our work would more purposefully engage with and integrate our commitment to community engagement and racial equity. And in that we identified 3 priorities, and 2 of them are very much tied to the focus of this work around the neighborhood level community health needs assessment. We had a priority focused on elevating support for Black, Brown, and Indigenous community research partners to build and sustain trusting research relationships and to promote community-driven solutions that advance environmental health equity, and also recognizing and values the efforts, skills, knowledge, and experiences of BIPOC partners to promote shared power and research partnerships and cultural reinforcement. So the work that you're doing, you're going to see today, you can go to the next slide, is resulting from this commitment. And I want to acknowledge key partners that are fundamental to making this happen. The work would not have happened without our support from Burton Bell Carr Development Incorporated, providing leadership, support with community outreach, dissemination, translation, and activation of the findings. Today, we're very pleased to have Joy Johnson joining us, and we're also grateful to Sharita Mullins and Bianca Butts for their support. From the Swetland Center for Environmental Health, we've been more involved in the design, analysis, and planning for dissemination. Excited to have Tim Ciesielski, Eleanor Giller-Lane-Hinkes, Owusua Yamoah, and Rachel Summer presenting today. And lastly, I want to acknowledge our partnership with Old Brooklyn Community Development Corporation, who was able to share their wisdom from completing a community neighborhood level community health needs assessment in terms of our design and process. And so specifically would like to thank Amber Jones for your support. And with that, I'd like to turn it over to Tim, who will provide an overview of what you can expect.
Thanks, Darcy. And thanks everybody for coming today. I assume folks can hear me. Let's just start very quickly here with an agenda. Basically 5 parts today. First, we're going to talk about phase 1 of the project, which was planning. Phase 2, which was data collection. Then we're going to move into phase 3, cover the results briefly. And then we're going to move to phase 4, most important phase, I think, dissemination and interpretation for action. So finally, we'll follow that up with questions for the panel and discussion. Next slide, please. So as we work through this agenda, we have 4 basic objectives. First, we're going to be describing the basic principles of community health needs assessments very briefly. Then we're going to clarify how we altered this process to achieve a hyper-local neighborhood level assessment. Then we're going to review the high-level findings and finally discuss the dissemination and action planning. Next slide, please. Okay, so I've been tasked with talking briefly about the planning phase. So next slide. Okay, well, what is a community health needs assessment? There's probably lots of folks in the audience that are very familiar with it, but just in general, is a process primarily conducted by hospitals to maintain their nonprofit status with the IRS. So typically, hospitals are expected to collect information from their medical records, the health department, and community-based organizations. And then they report on the resources they've been providing, and they estimate their future needs. As an example, based on the number of patients and diseases we treated last year from our service area, we need 50 new nurses, 9 new doctors, and we need an MRI to better serve our area. So in short, hospitals are leading these assessments because they're mandated to do it. They do include input from health departments and community-based organizations, and these are very important things that the hospital does. But generally, there's no direct input from the public, and it covers a fairly wide area. Next slide, please. Okay, so sorry, this slide didn't completely show up, but I'll just talk through it. How is a neighborhood health needs assessment different? So there's kind of 3 things, I think. The first is that it focuses on a small area. The second is that it features direct resident input. And the third is that it's not led by a hospital group. So this approach can help you to answer more fundamental questions, questions that extend beyond healthcare into prevention, questions that might come from resident experiences and insights. And that gets to why some of these pictures are up here. So do you have good parks and green access? Which streets need repair? Are guns a concern in your neighborhood? What about drugs? Asthma? What problems do you see? In its essence, we're asking, what are the drivers of disease and injury in a neighborhood? So if we can identify these things, we can build preventive interventions on a hyper-local level. Next slide, please. Okay, so there is some precedence for doing this. We didn't have to create this out of the ether. Luckily, Old Brooklyn Community Development Corporation had already conducted an assessment of this new type. So when Burton Bell Carr wanted to try this in Buckeye, Shaker, and Kinsman, Old Brooklyn and the Swetland Center were able to combine forces with BBC and help out a little bit. So the Swetland Center focused on supporting the process, developing the survey tool, and analyzing the data, preparing a report, and as well, as you can see right now, in disseminating and action planning. So, the benefits that can arise from the CHNA won't be restricted to healthcare because of the types of groups that are involved. CDCs, nonprofits, and city council and others can respond to these local findings. And these findings really do flow from the resident voices. And anything we do from these voices will be a custom ordered response to a community need or community insight. Next slide, please. So this is the last slide for me, and I'm, just giving people a little bit of context on where this assessment was conducted. So Buckeye, Central, and Kinsman are highlighted there. You can see that they are just a small part of Cleveland, which is just a small part of Cuyahoga County. What we find here is situated within what was found by the Cuyahoga County Health Department. So now I'm going to turn it over to Joy Johnson of Burton Bell Carr, and we're going to learn a little bit more about how this started from their point of view.
Thank you, Tim. Thank you, Darcy, and thank you to the Swetland Center and our partners. As Tim said, I'm Joy Johnson, and I'm the Executive Director at Burton Bocard Development. We are a nonprofit community development corporation that serves Cleveland's Central, Kinsman, and Buckeye neighborhoods. I usually say Buckeye Central and Kinsman because that's alphabetical order, because we do not prioritize one neighborhood over the other. Each neighborhood has its own assets and values and unique needs. And so that comes into play when we're talking about the community health needs assessment. We recognize that serving such a large geography means that there's these sub neighborhoods and each of them have unique needs. And so we actually conducted 3 assessments, one for each neighborhood. So we can go to the next slide. Oh, that's the only slide I get, huh? So I get to talk all there. Okay. So I wanted to talk a little bit about why a community health needs assessment was important. So Burton Bocard has been providing health and wellness programming for over 10 years, maybe closer to 15 years. We did it in alignment with publicly available data around the social determinants of health. We have health-based foundations in our community, such as the Sisters of Charity Foundation, which is affiliated with St. Vincent Charity Hospital. And so their work was directed towards health and wellness, and it was a natural alignment for us as a community development corporation. And so when we got the opportunity to replicate what Old Brooklyn had done in our neighborhoods, we thought it was a great way to get a different set of data, a different perspective. So instead of taking sort of publicly available data from the hospitals and such, hearing from the community themselves on where they saw their biggest health needs, health opportunities, and health challenges. And so our focus has always been, work that responds to data, but this gave us an opportunity to get a new data set. And it aligns with our mission of empowering citizens and revitalizing blighted and underserved communities. So this is an opportunity, this assessment is an opportunity to capture resident voice. That's very important for us. We do that in a lot of ways. We typically do it with real estate development plans where we get neighborhood input, but this is a way for us to capture resident voice as it relates to our programming. And so the residents will benefit because we will then design programming around what they identified in the assessment. And so we have a community that is over-surveyed, as I'm sure you all can imagine. That was something that we talked about a lot with our partners at Swetland and Old Brooklyn. How can we incorporate this into other activities? How could we incentivize folks to participate? We gave out $10 gas station gift cards. We asked people for 10 minutes of your time, and we'll give you $10 to complete the assessment. And in doing that with the gas station gift cards, we actually supported a locally Black-owned gas station, is where we purchased the gift cards from. So just trying to involve community in every facet of it, and looking forward to involving community in the implementation.
Thank you, Joy. I will now shift into talking about our data collection process. So our survey development really began with our focus groups. There were 5 listening sessions conducted in Buckeye Central and Kinsman with 27 residents and 8 community partners and organizations. And the purpose was really to connect with residents and stakeholders about what we should be focusing on before beginning data collection and to inform our survey development. And the findings from these focus groups informed what would become the priority areas for their survey, which you can see on screen. And our survey questions were developed from these areas of focus and the topics discussed and deemed important in the listening sessions. So we then went through an editing and refining process where we met and collaboratively edited questions and refined the surveys to our areas of focus. And we tested multiple versions of the survey with selected community stakeholders and residents. And we took this community feedback and then further refined the survey using what we learned so that we were focusing on what was deemed most important for stakeholders to learn, as well as for residents to communicate. And our next phase was survey distribution, which began on August 31st, 2022 and went until October 16th, 2022. Distribution began online. Surveys were completed through links that were distributed on social media, newsletters, and other listservs, as well as an in-person presence at community events. But surveys were primarily completed through the use of the street team. And the number of responses drastically increased once this team became active. And as Joy mentioned, all participants received a $10 gas gift card and were also offered to enter into a raffle for further incentives. And to go into a little bit more detail about the street team, they were hired by Burton Balcar, and it consisted of 11 members working in teams of 2 with 1 rover or leader position, who the team reported to at the start and end of each day, oversaw their route and kept track of all their compensation materials, and distributed survey materials to and from Burton Balcar to the street team. All of the members of the street team were paid $15 an hour for their time and efforts. And then their training was conducted in collaboration with the Swetland Center and Burton Balcar. We provided background on the project, like the goals and overview of the survey, as well as what a community health needs assessment is, as well as details on their roles and scripts and promotional materials for them to use and distribute. And then our final phase consisted of data monitoring and reporting. We used weekly REDCap reports to monitor the quality of the surveys, whether they were complete or incomplete, as well as representation, looking at race and age to make sure we were on target with our representation goals, as well as having an accurate reflection of the neighborhood demographics. We also did street team monitoring for Burton Balcar. We helped track who on the street team was helping with surveys and the number of complete and incomplete surveys they had. And this process really enabled us to adjust the street team and distribution efforts and target data collection towards underrepresented groups that we wanted to make sure the results were representative of the community, both demographically and geographically.
All right, thanks, Eleanor. In the next few slides, I will be sharing about the profile of the participants that were engaged in this process and also a summary of key findings by neighborhoods. This is just a summary. All the details have been shared in the report that Rachel will be talking about after I present. So I'm going to start first with the profile. Go to the next slide. So across all 3 neighborhoods, over 80% of the survey participants identified as Black or African American, and this racial distribution is very representative of the neighborhoods that we did this CHNA with. As far as age, about 1 in 4 were between the ages of 25 and 34, and 50% identified as female. If you look at the median ages of the participants, you could tell that respondents in Buckeye were much older compared to those in Central and Kinsman. You want to go to the next slide, please. For education, over 87% of all participants had a high school diploma, and we wanted to highlight that this is greater than the percentage in Cleveland, which is 82%, but also less than the percentage of people with high school diploma in the county, which is about 91%. Also, among all the 3 neighborhoods, participants from Kinsman had the higher educational attainment compared to the other 2 neighborhoods that we work with. For employment rate, participants had a much lower employment rate compared to Cleveland and Cuyahoga County. So among the participants that we surveyed, about 55.3% were employed for wages at the time of this survey. 10.6% were out of work and 19.3% were retired and unable to work. The chart here shows distribution of income among all the 1,400. About half reported an annual income of less than $20,000, which is less than the median income of Cleveland and Cuyahoga County. We did note that the lowest median income was recorded in Central. I'll go to the next slide. Here is some data on government benefits utilization. As we know, supplemental benefits are forms of government assistance used to help to provide resources for households with lower income. We did find that SNAP and housing assistance were highly utilized among all participants, but predominantly in Central. WIC and TANF and Social Security income were utilized more in Buckeye compared to the other two neighborhoods. I think overall SNAP was higher among survey participants compared to Cleveland, where in Cleveland it's about 33.4%, in Cuyahoga County it's about 41%. But among our participants, we had almost half of our participants were receiving SNAP at the time of the survey. Go to the next slide. So next, I'm going to share briefly about some of the key findings for each of the neighborhoods. As I said, these are just highlights. There is more details in the reports. So you don't go to effects, the next slide. So here is some key findings from Buckeye. So overall, we did find that respondents in Buckeye were very optimistic about their neighborhood. About 68% believed that the neighborhood was changing for better, and close to 60% also wanted to remain in the neighborhood. We found that gaps were identified related to access to healthy food, green spaces, safety, and healthcare. Now, when we think about access to healthy food, we did find that about 40% of respondents indicated that they could not purchase healthy foods in their neighborhood. And almost a third reported that there was a time in the past 12 months prior to data collection that they did not eat because they did not have enough food at their home. This is an indicator of food insecurity, so it's very important for us to highlight that data as well. In terms of safety, gun violence was a concern for residents. About 60% worried about being victims of gun violence in the neighborhood, and improving safety was identified as one of the top 3 priorities that would improve health in the Buckeye neighborhood. For health, emergency room utilization was high, and there was also a need for mental health care, which was highlighted by the data that we received. About 30% of participants said that they or someone in their household had been diagnosed with anxiety, and 21% had been diagnosed with major depression. And go to the next slide. So now providing a summary about Central. So in Central, we found that respondents had higher sense of belonging, but then overall optimism was lower compared to the other neighborhoods. Almost 70% felt connected with their neighbors, which indicate that sense of belonging that I mentioned. But then about 57% did not agree that the neighborhood was changing for better, and less than 1 in 2 wanted to remain in the neighborhood. Here again, the gaps that were identified were related to access to healthy foods, green spaces, safety, and healthcare. With regards to healthy foods, 81% desired a grocery store in their neighborhood. And about 78% of respondents said that they would purchase healthy foods if it was available in their neighborhood. More access to fresh and healthy food was also identified as a priority in improving the health of residents in Central neighborhood. Respondents also mentioned that quality and the number of green spaces and rec facilities in their neighborhood were inadequate to meet the needs of the residents in their neighborhood. There were also several barriers to health and healthcare access that were identified, which also included high utilization of ER and also high prevalence of hypertension among residents. About 40% said that either they or someone in their household had been diagnosed with hypertension. As far as safety, neighborhood safety was a concern for residents, with almost 60% indicating that they or members of their household had been affected by gun violence, and also 65% felt unsafe in their neighborhood at night. And go to the next slide. So the final neighborhood summary is about Kinsman neighborhood. So for Kinsman, among the participants that we surveyed, we did find that there was a high optimism and also a higher desire to remain in Kinsman. About 60% or more agreed that the neighborhood was changing for better. They wanted to remain in their neighborhood and also felt welcome in their neighborhood. Again, gaps identified also were related to access to healthy foods, green spaces, gun and traffic safety, as well as healthcare. So for respondents in Kinsman, the number 1 desired retail business was a grocery store. And here again, about 35% said in the past 12 months, they did not eat because there wasn't enough food at a point in time in their household. They also desired more recreational and green spaces in their neighborhoods. Also, limited access to healthcare services was evident in the high utilization of ER, and also a desire for pharmacies in the neighborhood. So that was also one of the top retail businesses that they desired in the neighborhood. And then finally, as far as safety, gun violence and traffic safety rose to the top for respondents from Kinsman. Respondents were concerned about speeding and also gun violence in their neighborhood. About 51% indicated that gun violence prevented them from enjoying their neighborhood. So those are the summary highlights for each of the neighborhoods. You want to go to the next slide? So I know most of us are aware that the Cuyahoga County also released the CHNA for the county. So at the time that we were doing this process, the county process was also ongoing. And since these neighborhoods are located within Cuyahoga County, we were very interested in identifying areas of alignment or otherwise with the county CHNA. So on the left of your screen is the 6 priority areas that we identified through the neighborhood CHNA. And on the right is the 3 priority areas that the county identified in their CHA process. Obviously, if you see there is a lot of alignment with what was prioritized in the neighborhoods compared to what was prioritized in the county. It's very important to note that our process, however, provides neighborhood level data and also give the opportunity to tailor actions to specific neighborhoods. Although they align with the county, this process gives more like detailed data and more ways to for funders and other people who are doing work in the community to support some of these actions that are recommended in the reports. So I'm going to hand it over to Rachel to talk more about dissemination and interpretation for action.
Thank you, Owusua. As Owusua said, I'm going to transition to speak more on the process of taking these findings and translating them into pieces that make sense and that are useful for different audiences, with especially an emphasis on collateral materials that are relevant for the people in the communities in which the community health needs assessment was conducted. On the left-hand side of my screen, you can see one example of one of the community health snapshots that we prepared for the Kinsman neighborhood. You probably see some of the data that Owusua shared. This is the front side that really focuses on the demographics and who was sampled in that community. And as I go to the next slide, I'll explain more about our materials. So the development of these materials was a long but very important process. As you can imagine, we had a lot of data from the 1,402 surveys that were collected. So it was important to all of us working together to consider how this information could be presented in a way that was transparent, meaningful, clear, and useful to many different audiences. So the key pieces of these reports are as follows. We have a technical report, which includes every question and a summary of responses to each question in total and by neighborhood. So those of you who are data nerds, you can get in there and get deep into it if you would like. And then I think it's especially helpful if there's certain topics you're interested in or community groups that are working on certain issues can jump to those questions. We also have the full report, which is a high-level overview of the process, the neighborhoods in which the process was conducted, findings across neighborhoods with highlights from each neighborhood that are significant, as well as the implication of those findings for taking action on the priorities identified by the residents of these neighborhoods. The community health snapshots you see here on the screen, we have one for each neighborhood, Central, Kinsman, and Buckeye, and those are intended to provide a summary of the neighborhood findings, both looking at demographics, as I mentioned, and highlighting the pertinent health needs and strengths of each neighborhood. The community health snapshots were screened to use language and images that were more accessible to neighbors of these communities. And based on what the individuals in these communities said that they would like to see happen, you'll see at the bottom of each health snapshot some suggestions of improvements that could be made or what the neighbors would like to see happen. So we're in the process of dissemination now, but there have been a series of neighborhood meetings happening, and that will continue to occur where this information is shared. And Burton Bell Carr has the wonderful benefit of the community radio station, if you're familiar with WOVU, where messaging will be shared, as well as targeted meetings with stakeholders, both in the neighborhood and beyond. And I will be putting links in shortly, but you'll notice both in the full reports and in the neighborhood community health snapshots, we have opportunities for action. And so as our team of partners and stakeholders, including our partners at Burton Bell Carr, met to plan for dissemination and action, we were able to develop some suggested priorities for action based on what is tangible, actionable, and has existing support or infrastructure in the community. So I won't read through all of these right now, but one example is related to mental health. Creating a campaign to address the stigma around mental health services rose to the top as a priority to act on. Complementing this suggestion is to provide support and expand funding for programs that already exist in the community. One program some of you may be familiar with, called Ghetto Therapy, is a trauma-informed group therapy model that takes place currently in the central neighborhood and has had a lot of success. It should be noted that the suggestions and recommendations on this slide are initial suggestions, but they really need to be fully vetted and decided on through a community process. And that brings me to a point that I would like to share, is that the members of this team and partners believe that acting on these priorities would really be best supported by a funded coordinator role to engage with community members, leaders, and organizations that are interested in acting on this work. However, it is important to share this data now because the act of sharing allows this information to get into the hands of the people who are doing this work currently. We know there's many individuals and leaders that have been working on these issues for a long time. And the goal is to supply additional tools and information to direct the work, as well as inform new ideas and solutions. So we anticipate that the dissemination of these reports and findings will continue alongside the action planning process for the foreseeable future. The dissemination materials that I mentioned earlier are currently on our website, and we encourage you to share them broadly. And we're really hoping this will ignite action across the community. I will be putting in a moment, or somebody from my team will be putting a link to where you can find those materials in the chat now. So you'll find the tech report and the community health snapshots online now. The full report is in final stages, but should be ready in the next few days. So lastly, I just want to say, if you would like to stay in touch to get more involved with the implementation and action planning related to these findings, we encourage you to contact Burton Bell Carr, and their information is on the screen. If you have questions about the data and evaluation portion of this work, you can contact me and I'll be happy to answer your questions or direct you to the appropriate member of our team who can address your questions. So with that, I'm going to turn things over to Darcy.
Great. Thank you all so much. Amazing work that's been done. You all are just getting a snapshot here, but we wanted to also provide an opportunity to hear a little bit more from our panelists about their experience with this neighborhood level community health needs assessment. Before we dive in, I want to acknowledge our funders and dissemination partners of this work. This work would not be possible and certainly wouldn't be shared at this level without the support from the Mount Sinai Health Foundation, St. Luke's Foundation, the Ohio Department of Health, the Sears Swetland Family Foundation, Burton Bell Carr Development, Inc., United Way of Greater Cleveland, Better Health Partnership, and the Cuyahoga County Board of Health. And so as we are reflecting on what we heard, Tim started off saying neighborhood level community health needs assessments are really moving away from healthcare to prevention. Not to say that traditional aren't focused on prevention, but this one has a very explicit focus of thinking about what would it take to improve health by focusing on the places where we live, work, learn, play, and pray. And it also, the findings from this validate what we found at the county level about broad opportunities for community health improvement, while providing more specificity for the neighborhoods, these specific neighborhoods. So I want to start off with Joy. and sort of reflecting on the experience and process, what do you see as the next steps for Burton Bell Carr, and how are you planning to use the findings from the assessments?
So I think that the next step for us is actually acting on the recommendations that came forth from the assessment. And I would say first, sort of testing it out in the community, sharing those recommendations to see, did we get it right? Is this on track with what you had in mind? And then really working with the residents to say, here's how this has been done in other places. Here's some ideas we had. Tell us what you think, and get the feedback around it so that we could begin implementing programs or projects that address those needs that were highlighted.
Great, thank you. I think, one of the other challenges in this work, we heard several times, there was a street team collecting data, 10 minutes for a $10 gift card. So that meant you had to have a survey that was really focused. Owusua, can you just tell us a little bit about how did you decide what questions to ask in the focus group to help narrow in on the content of the survey?
Thank you, Darcy. I definitely believe that was one of the challenging phases of the project. It's like, what do we focus on? There's so many questions you can ask. I think one of our priorities right from the beginning was that we wanted to engage our partners and the community in every stage of the process. So for the focus group, the main goal was hearing from the community in order for us to know what to ask. But then even going into the focus groups, the listening sessions, and determining the questions, I think there were 2 or 3 main things that we did. So first of all, our partners at BBC, they work in these communities. They've been there for several years and they know the communities. So their inputs in deciding what to ask was very important. Again, we also wanted to have open-ended questions that are structured in the way that the community can freely talk about things without us putting in so many guardrails on what they could discuss. So that was also another thing that we did. We also looked at other CHNA processes that has happened. You've heard about the Old Brooklyn one that was done in the past. That was one that we looked at. We also look at others across the country, looking at their process, looking at what they did, and running it by our partners. Here are some questions. What do you think? What do you want us to ask? So it's basically a more collaborative process in determining what they wanted us to include in the focus group, which eventually determined what we included in the surveys.
So again, we heard about this amazing street team. Eleanor, can you tell us a little bit more about the street team and how did you prepare the team to engage in data collection?
Yes, I can. Thank you. So a large part of the street team training itself actually ended up focusing on getting the team members familiar with the technology, specifically the tablets used to collect these survey responses and the survey itself. So we spent a lot of time demonstrating how to access the survey, making it easy for team members to access, either through linking the survey on the tablet directly or getting larger tablets that were easier for people to use. We also spent time going over how to make sure responses were submitted so that it's reported as complete, how to fill out the form for the raffle and go back and forth between the survey and different links, how to handle any errors or issues that may come up, and generally just having them go through it multiple times to become familiar with the survey and so that they were able to help others take it. And then we also checked in periodically through BBC to answer any questions that the street team had or help solve with any issues they were experiencing, whether with the tablets or with the survey itself.
Great. Thank you, Eleanor. And just to, for those who are on the call, were you able to provide any compensation for the street team for their work?
Yes, we did. Now, I don't remember how much it was, but it was enough to make it worth their while. We had a really committed street team, and I wanted to make sure folks knew that they were residents of the community as well.
Awesome. Thank you, Joy.
I believe Eleanor mentioned it was about $15 an hour. Is that right, Eleanor?
Yes, that's correct.
Okay, perfect. So Rachel, we know that sometimes things don't go exactly as we would expect with any process. So from your perspective, what were some of the challenges to the neighborhood level community health needs assessment that you can share as lessons learned or feedback for other groups that might be interested in replicating this approach?
Thanks, Darcy. So as Joy mentioned, the community and many communities across Cleveland have been over-surveyed. And I know for me personally, my fear at the beginning is like, let's make sure that something comes of this that can be useful, that can be acted upon immediately. And so I think one of the biggest challenges for the team, but for me also is, finding the right balance between like, when is the right time to share the data? Like, as you can see, even on the website, we're like still waiting on the final report, and having enough suggested actions and framing the priorities in a way that they're actionable so that groups and individuals can act on them, even if we don't have like a full, like, this is the implementation plan. I think it's nice to always like come to say, okay, we found the issues and here's the solutions, but you also have to still make sure that, as I said earlier, it's community driven. So we wanted to get the data out as soon as possible so that like building trust and transparency that this is from the community, it's for the community, and we want them to be able to use that in a way that's most meaningful and appropriate for what's important to them. But knowing that we still want to continue to build some support to help coordinate that work to create some collective action. I think if we have the opportunity to fund a coordinator role to coalesce actions around these different priorities, it would be less being the person who says like, oh, this is what we're going to be doing, but more kind of framing, telling the story and highlighting the groups that are already doing this work, or maybe helping to find additional resources to support new endeavors that the community wants to embark on. So I hope that answered the question.
Yeah, I think, hearing that tension of, collecting the data, which of course you heard here today, it takes quite a bit of effort. It's very unique to have this level of data related to a neighborhood specifically, or 3 neighborhoods. But then the movement from, learning in a more holistic way, but also then moving into the activation phase. And I think, hopefully today is the beginning of a process of democratizing the data, making them available to anybody. Of course, there have been partners that have been working. You've heard from them today. But many other groups are doing amazing work in the community, and I think, have lots of opportunities for activation. And so that sort of turns me for a minute to a question, Joy, that we had from Rachel Oscar about, often the work of data collection reinforces what you already know, community groups or CDCs, because you've been connected and seeing on the ground what's happening. So was there anything that emerged from this report that you were particularly surprised by? That's coming from Rachel.
Thanks, Rachel. That's a good question. And there was quite a bit that I was surprised by. I think Owusua shared that in Buckeye, folks talked about not having access to healthy food. And if you were to look at Buckeye on a map, there are 2 major grocery stores within the footprint. There's a Dave's grocery store and there's a Simon's, along with other, a Dollar General, Family Dollar, which has, relative levels of food. So if you just looked at proximity to a grocery store, you wouldn't expect folks in the neighborhood to give that answer. So there's some sort of disconnect. Maybe what the offerings are in those particular stores aren't what people see as healthy. So that was eye-opening. And I think the biggest one for me, also Buckeye, maybe because I lived in Buckeye for 10 years. So I was like, okay, this is surprising. But I can't remember in Buckeye, people reported going to the emergency room 5 times in a year. And that was higher than the other 2 neighborhoods. And Buckeye has a clinic of Metro Health in the community. And so, again, if you just look at proximity, you wouldn't think that folks would utilize the ER that much. And then I just think personally, like when I pulled my side muscle and I had to go to the ER, that bill was like $2,000. So I can't imagine. And I know everybody's insurance is different, but just the financial burden if you're going to the emergency room 5 times a year, on top of all of the other indicators that gives. So those were two of the surprising findings for me.
Thank you, Joy. I want to open it up. I have a couple of additional questions, but I wanted to make sure that we had time for anyone in the audience who might have a question that you would like to get a little bit more feedback from our panelists. So if you want it, you could either put it in the chat or just come off mute and ask it yourself.
I know Joy just answered one of mine, but your point about cost burden related to emergency room, I'm wondering, is there, that was such a high statistics in all the neighborhoods of the frequency with which folks go to the emergency room. Is there any data or work to put a number to that percentage? How much is what that cost burden looks like related, or how much we could be saving if people are diverted from? I'm wondering if there's info that could be collected around that.
Yeah, I'll add, in the recommendations, and again, we aren't able to go into a lot of depth, but one of the areas of focus, I think innovation opportunity is around primary care, and trying to think about what would it take to, because there actually is some primary care in the community as well, but what's the opportunity for making sure primary care that's available is accessible when people want it? And I think this is a challenge. The healthcare system as a whole right now, I think, is struggling. It's very hard to get into many primary care spaces. And so the emergency room is sort of like the easiest way. But it's, of course, as you said, not financially a good way. And it's not good actually for healthcare, for individual health promotion. So I think that that's an innovation space within, as a finding from this work. Go ahead.
Sorry. I just wanted to reinforce what Darcy just said, and also add a tiny little piece that, it probably would require a little bit more research to dig in the details of some of the possible reasons that Joy and Darcy just alluded to as to why is this the best way to get healthcare in this area? It may not be people's first choice. They may want to have a primary care, urgent care, but it's not working however it's set up. So in terms of the costs and how to fix it, I do think it would require a little bit more research in this question.
There was another question about other data being collected in the community, including the neighbor to neighbor survey. And we were aware of that, and actually specifically didn't ask about things like internet accessibility because we didn't want to be duplicative, to the point earlier being over surveyed. So unfortunately, Amy, we do not have that, but I think it's an area where you could overlay the data.
And I believe we did have some initial meetings with the coordinator that worked. It may have been Tim and I am trying to remember, it was a while ago, and we kind of each went over our process and our timelines and project. And so it was good to share and to know where each one was at, but based on kind of where they were at in their process and when we were going to activate, we couldn't align it in a way to do both at the same time, but we were trying to kind of keep tabs on what one another was doing and think about how that information may complement one another.
If I can just make a suggestion, it's very helpful to hear that background. I think it's important when you present your results to be clear that you intentionally left internet out, because otherwise I think it's easy to walk away with the impression that, well, internet isn't an issue in this neighborhood. And as you know, Cleveland is working really, really, really hard to attract funding to close the internet gaps. And so, I think just underscoring that so that you don't inadvertently kind of undermine that message would be really helpful.
Yeah. And I think linking with that's a good suggestion too, coming back to that group and seeing what did they learn around these specific neighborhoods and making sure there's a blended story there. Thank you for that recommendation.
I don't know if we have time for one more quick
Yes.
question? Thank you. So sorry, I'm calling from my phone, but I thought that was, yes, a wonderful, it was wonderful work with the community to elevate these specific issues that need to be addressed. And the one that caught my attention is this incredible feeling of a presence of violence and gun violence in each community. And yet two communities seem to be a little bit more optimistic. They seem to be more connected with their neighbors, whereas in Central, things seem to be a little bit more on the dismay. And I thought that would be a really interesting step for further exploration. What is it is there something that we can hold on to, continue to, build that community, and at the same time, with positive interventions, reduce the excess violence, things that erupt out of despair, out of just having a community be neglected for so long. So just that, I thought that would be really important to follow up on.
I know during the focus groups, we talked a lot about just like simple things that residents wanted, and it's in their report too, but residents shared both in the focus groups and in the survey, they were like, if we could just have lights that worked, on the street, and I always say, like, I feel like when you shed light, it takes away darkness. Like, we know that nefarious things happen in the dark, and it's like a very practical and easy thing to act upon. And I think it was on the slide I shared there in the other, the recommendations, but like, could we get a task force together to audit all the streetlights that are broken, or where we should put more lighting in, and, having a reporting system when they're out, like maybe through the mayor's 311. I think it's a very small, not to say that it would solve everything, of course, but it would, bring a sense of safety feeling to the residents, and also perhaps detract from some negative activity. And it's such a small ask, and I feel like the residents deserve that much, right?
So I'm going to go ahead and wrap us up because there, of course, we could stay on and continue to talk, but I want to remind you that Rachel did share the website that has links to the neighborhood level reports, the technical report. The summary report will be coming soon, and we will make sure everybody attending this meeting today will receive a copy of the full summary report when it's available. It will also be available on Burton Bell Carr social media and website. And of course, many of our partners will also be spreading the word. So you'll probably see more and more promotion of the work that's been shared today. I want to close with a question for Joy. I know, Joy, this was a great opportunity, but also came with a lot of learnings as we go. And so as you're thinking about the experience of doing the neighborhood level community health needs assessment, what is one piece of advice that you have for groups looking to engage in similar processes?
Ooh, Darcy, that's a tough question. I think maybe sometimes it's just the quantities. This is a very simple, it's not a very philosophical answer, but taking on 3 neighborhoods at once, each with its own unique identity, just demanded 3 times the attention. So if I had to do it again, I probably would have picked one neighborhood first and really knocked it out and learned from, our mistakes, and then applied that to other 2 neighborhoods. So nothing really profound, but just more of like order of operations type of thing.
Excellent feedback. And I think those are the kind of lessons where, I think as other people and more groups are looking into doing these neighborhood level reports, I think that's great feedback. So you all can find us and learn more. And I know you're probably going to hear most directly from BBC coming up in the next few months about continued ways to learn about, engage with, activate data coming from the report. But we want to communicate to everyone here that these data are available for those folks working in the community to activate. So please use the data and start to think about how you can collaborate for community-driven change in the neighborhood. So thank you and have a great rest of the day.